Testing. We have sound. Do we have focus? This is the world's most overkill webcam. Look, Twitch streamer. Hello, everybody. My name is Ollie. Welcome back to the channel. I'm a resident doctor about to start neurosurgery training in a few weeks. The Leng review is finally here. The independent review of the physician associate and anaesthesia associate roles. This is an independent report commissioned by West Streeting on behalf of the Department for Health and Social Care. This review has been done by Professor Gillian Leng, who is the previous top bod at NICE, the National Institute for Clinical Excellence. So someone very au fait with the evidence base and making evidence-based judgments. This is a 130-page report and it is 11 p.m. and I do not have time to read the whole thing. But what I think we could do is take the major sections, so the background, the scope, the methods, and this recommendation section, because that is ultimately the thing that's going to influence us all. I think there will be some key shorter messages to take away from all this, but this is me reading it in depth for the first time as well. I know what the headline sort of statements are and some of the recommendations, but I've been in the middle of moving house. As you can see, it's chaos and not my normal setup. So I've not had time to sit and digest it, but let's just go for the executive summary. I'll go through each bit. This is probably going to be a longer video, quelle surprise, but we can go through the key ideas, the key concepts, the recommendations, and what I think. And if you've not seen the video where I predicted what we might see come out of the Leng review, then go and check my video out, which will be linked in the video description from a few weeks ago, where I wanted to get ahead of the curve and try and get some predictions out. So let's just go straight in. PAs and AAs, which are collectively called MAPs, Medical Associate Professionals, for the purposes of this conversation, introduced into the NHS in the early 2000s, part of a development of wider multidisciplinary teams with this focus of allowing doctors to focus on more complex cases, doing doctor stuff, while enabling access to more patients and this perceived idea of improving efficiency. The relative length of PA and AA training compared with doctors was seen as giving a more rapid route to alleviating workforce pressures in the NHS. So for some context, it usually takes 5 years to train a doctor as an undergraduate. The PA course, for example, is 2 years, delivered as a postgraduate diploma or a master's degree at level 7. That's this obvious idea. If you can get people into the clinical workforce with a 2-year thing rather than a 5-year thing, that's going to be faster and mean you can generate more people quickly. Expansion in numbers over the last 10 years has begun to generate challenge from medics. So she's carefully said the medical profession here. That means doctors for the purposes of this. Public and the media, exacerbated by workforce pressures, post-pandemic stuff, and made worse by IA and strikes. Concerns raised about safety and lack of clarity, and impact on training employment of residents, because you're trying to train up essentially people to do a lot of the same stuff that historically would be and is still done by resident doctors. So in the context of limited training, this can put pressure on people. So autumn 2024, this review was commissioned to help work towards this new NHS workforce plan, which still has not been published yet. We've seen the 10-year plan. We have not seen the workforce plan, which is going to be a new report that we expect, I think, in the coming months. This is important. The aim of this review, so the aim of the Leng review, was to determine whether the PA, physician associate, and AA, anaesthetic associate roles were safe and effective as members of the MDT. There are secondary questions about what modifications might need to be done, looking at the actual rollout itself, but safety and effectiveness. I think remembering that, like with a research study or whatever, you have to define your aims and your terms. Safety and effectiveness are the focus of this report above all else, because there are so many questions that people had about training, pay, cost effectiveness, all of these things. These are interesting but not the primary goal. So what has she done? She's done a massive independent literature review looking at all of the published evidence that exists in the academic space. National bodies, CQC, NHS trusts locally, looking at mentions of these roles in prevention of future deaths reports. I think they're called Section 28 notices. But when patients die and unexpectedly or difficult cases get referred to the coroners, they sometimes issue these reports. 8,500 people completed a survey giving perspectives on the roles, and then they ran 3 patient focus groups, and then Prof Leng did this visit to many different sites in the country, and I'll talk about that a bit later because it was a bit fraught. So the most key thing, what was the evidence that she found in this literature review? Research, that is existing literature on safety and effectiveness, was limited, generally of low quality and inconclusive, or demonstrated a mixed picture. Studies showed little attempt to compare or account for variation in case mix, supervision arrangements, or patient outcomes. Interpretation of findings was therefore challenging and had to be contextualized and informed by judgment. So I can tell this video is already going to be long, but there's a few things that make this really, really difficult. My first question is, the report opened by saying that these roles were introduced in the early noughts, in the early 2000s, and 20 years later, there is very limited evidence, and what there is of low quality. As an early careers academic, that worries me, because what that means is that people have been making what is effectively a clinical intervention, substitution of staff groups and trying new ways of working, without monitoring or ethics or, quality assurance processes going on. This is just something that's been decided, clearly run with, without the types of evidential underpinning and scientific inquiry that you would want to see in a clinical intervention. Think about what is needed for a clinical trial to be run. Testing for non-inferiority, which is what you would need to do if you're looking at staff substitution. So that's one thing. Why is there such limited evidence? The second thing is no accounting for case mix. Obviously, this is a huge thing, because if MAPs are given a different cohort of patients to look after, which I think is reasonable to expect, they may be seeing people that are less hyperacute or less medically complex. You need to account for that in any measure where you're looking at safety, cost effectiveness, because if what that means is that your doctors are seeing all of the most complicated cases, they're going to take longer, they're going to order more investigations to do that. The outcomes of those cases might be worse in terms of reattendance or all-cause mortality. You have to control and account for all of these things when you're trying to compare performance between different groups or different arms of an experiment. Supervision is obviously absolutely key, because both PAs and AAs are what are called dependent practitioners, or they practice essentially via delegated authority from a senior supervisor. And obviously you need to know how close that degree of supervision is. If, again, you're trying to make judgments about quality of performance or outcomes, because if the consultant is right there next to them all the time, then probably what that means is that the consultant is absorbing most of the complexity and providing additional efficiency, whereas if a person is practicing with very little supervision, perhaps the consultant is somewhere else or off-site or not even at work, then the whole safety coming from supervision angle is gone, and that case mix might be inappropriate. So it's, the only word I can really give is disappointing that in such a risk fraught area when you're dealing with medical complexity, workforce substitution, that people have clearly made conscious decisions from the top down to not gather evidence or put controls in place properly. That is concerning when you're rolling out any clinical intervention, not just in this case. So PAs. In primary care, research was limited and neither compelling that they were safe nor unsafe in terms of outcomes and comparators. I mean, fair enough. PAs were associated with fewer hospital admissions or readmissions, which may or may not represent a positive outcome yet. Unless you know the complexity of these cases, it's almost impossible, because that could mean that they were seeing a more complex cohort who would have higher rates of readmission or going to hospital, or they were missing things and people weren't being sent to hospital or weren't being readmitted when they should be. That's not a negative comment on PAs at all. It's just it's kind of useless unless you know the nature of the cohort that you're dealing with in terms of patient complexity, comorbidity, etc. In secondary care, most research focused on ED and not award-based care and mental health. Studies were small and inconclusive. No difference in outcomes for PAs relative to comparators, and FY2s were used as the most common comparator. More PAs were named in Regulation 28, so that's these prevention of future death coroner's recommendations, than expected, but fewer in never events. I have no idea how you calculate this, by the way. There were more studies on effectiveness. Outcome metrics were narrow, conflicting results, little or no difference. Basically, it's very difficult to take much from this other than the evidence base is a bit crap and the studies aren't properly powered to show much of anything interesting or controlled properly. Then looking at AAs, no published research looking at the safety of the AA role, several local audits. This data was of low to very low quality, due to small sample sizes, pre-pandemic, lack of consideration of case mix. It makes it very, very difficult to do anything with. With these caveats, the performance of AAs appeared to be in line with national standards and comparators, generally either consultants or anaesthetists in training. Again, it's difficult to know what to take from that and what prof means by performance, because obviously you wouldn't expect the performance of an anaesthetist in training to be that of a consultant. The way that this is worded, it makes them all sound homogenous, and I don't really know what she means by performance in that sense. Patient and public opinion. Patients tended to be satisfied after seeing a PA, had a positive experience, felt listened to, but were concerned by lack of clarity, confusion with a doctor, barriers to care. If a prescription was required, PAs in the UK cannot prescribe at the moment. They're not on the list of roles that is allowed to prescribe, and lack of confidence in whether they were seeing an appropriate medical professional. Many doctors expressed concern about time required to supervise, the absence of training to do this well, and the lack of understanding about how supervision would work. Potential safety incidents were regularly picked up and prevented. I mean, I guess with that's what you would want to see. Like, it's good that doctors are looking out for these things, but if I was taking on supervision burden for another staff member, I would really want to know what is my responsibility, how much do I need to be checking what they're doing, how often are we going to check in, what do they need to run by me, etc., etc. There's just so little guidance on what supervision actually means. The review survey for PAs showed marked differences in which tasks were considered appropriate in primary and secondary care. PAs more likely to believe that certain activities were appropriate for them to carry out. I think there's a graph that shows this, but it does show this. There is this enormous difference between what PAs perceive or believe is appropriate for them to do based on their skills, training, and experience, and then what doctors believe is appropriate for them to do. You obviously have to take note there that doctors have significantly more training, so that's going to cause a real clash naturally. Results from other surveys showed similar discrepancy with AAs. There were differences in the views of clinicians, with those currently supervising AAs being a bit more positive than those who weren't. An important consideration for anaesthetists was whether the service actually needs this non-physician role, as there are very high competition ratios for anaesthesia specialty training. Yeah, it's crazy at both the junior level and the senior level. Competition is very, very stiff to get into anaesthesia training at all, to become a consultant anaesthetist, at a time when we are very short of anaesthetists. And you have to understand that in the background of all of this, the government decides ultimately how many anaesthetists are going to be trained, because they fund the training pathways to make more anaesthetists. They know full well, and have known for years, that we are very short of anaesthetists now, and we are projected to be short of anaesthetists into the future. The answer to that is you have to open the bottlenecks and train more, otherwise you're not going to have anaesthetists. And someone did an analysis of the cost effectiveness of the AA role as it's currently banded. My recollection of that is you need to be working at a ratio of, I think it's 3-1 consultant anaesthetists to anaesthesia associates to make the finances work. It was either 3-1 or 4-1. I can't remember. Both of which go above the 2-1 ratio, which is the maximum that I believe the RCOA endorses. Publication of the long-term workforce plan in 2023 prompted significant concerns because these roles were going to expand massively, basically. Most people recognise the need for a more diverse future workforce. The things I don't actually, like myself, I don't necessarily buy this. I think that is instinctively one of those things that you would think was true, but I'm not sure that it is actually true. There was concern that there are more types of staff role in the NHS than any other healthcare system, and a lack of clarity about how they should all interact, and that is exactly one of the key problems. Unless you know who is doing what and who is trained to do what well, and everyone understands their role in this system, and you don't end up with this like homogenous hodgepodge soup of people doing different things, which becomes more inefficient. These two things need to gel together. That was not made better for me with the government talking about in the new 10-year plan this idea of training to task, not training to role. That is this exact problem put into one phrase. We can just train a practitioner to do every single type of task we might possibly need. It doesn't work that way. That's not how professional training works. Often concerns related less to PA and AA roles, but more to unhappiness about changes in training. I think that is a fair comment, particularly in this letter I wrote that I referenced earlier and sent to this journal. That was basically why do the colleges, why do the government, why does NHS England choose for medical postgraduate training to be so crap, basically, and so difficult, when clearly some of the same objectives are very possible to do much more easily with these roles that don't rotate around, simply because someone decides that is the way that it's going to be. And it is this key thing, fragmentation of the medical team, because you had these two situations where doctors, as we all know, are required to rotate very extensively. So foundation, you'll rotate through 6 jobs over 2 years. then you'll rotate basically all the years of your training every so often to get the specialist experience that you need. That continues basically all the way through. Doctors have to rotate here, there, and everywhere to make sure that they're exposed to lots of different types of medical training in many different places, to make sure that their experience is broad enough and they are well trained enough to do everything that they need to do to look after patients and keep them safe. Some units clearly decided, well, we're so frustrated by the fragmentation and rotation that we'll simply train our PAs and AAs to do what we want them to do to meet service need without any rotation at all, because they just work in that department, which demonstrates to everyone that this much more stable, reliable model of training is completely possible if people choose for it to be. But either then those people that don't rotate aren't safe to be looking after patients in the way that doctors do because they don't rotate, or the rotating that doctors are doing is completely superfluous, even though it's very stressful, very difficult, and puts an enormous amount of strain on people. So you've got this complete double standard, effectively. Regulation of these two roles began under the GMC in 2024. This was the AAPO order. I should note that was put through via statutory instruments. It was kind of a workaround to changing the law to get this to happen. They're not required to register legally yet, but this has not been welcomed widely by many because the approach taken doesn't help in distinguishing the roles. And the GMC, the particular way that they've dealt with this, they make very little distinction. They apply good medical practice to all three groups, despite the fact that by their own documentation, neither PAs nor AAs are considered to study medicine or practice medicine or be medical professionals. They are still governed by the General Medical Council, and they apply good medical practice to them with no distinction in standards between the different groups, which just seems crazy to me in the way that they've chosen to implement it. So we're now on to just some more relevant factors before we look at the recommendations. What have we got? A clear vision communicated effectively. I mean, this is more broadly about lessons learned from the rollout, which I think most everyone can agree was a disaster. The rollout of these roles and how they've tried to be integrated into the health system or not integrated, as is the case. That is not the fault of PAs and AAs. That is NHS England and DHSC between them. It's been a complete shambles. No nationally described vision for integration into existing services, and they've just gone expand, 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 train more and more and more because there are patients to see. We need to bring spend down, just make more and we'll figure it all out later. It's terrible. There was no single consistent voice. Leadership could have mitigated the challenges of rollout. I agree. Leng talked about this a lot in the webinars. Where capacity was limited in local services, gaps in medical posts were sometimes covered by PAs without taking into account their more limited training or ensuring that supervisors had understanding or timed skills required to give oversight. That's, I'm sure everyone can agree, completely unacceptable, because as Leng herself says, a PA does not have the training that a doctor has at any level, and it's therefore completely unacceptable that a trust could have even made the decision to plug medical gaps with a PA. Like, it's we're getting into the sort of territory where I don't understand why that's just not illegal. Because it's doing a regulated practice without being appropriately trained or regulated to have done it. So, to me, managers should have been sacked or clinical directors moved on, not allowed to be in a leadership position if those decisions were being made. Like, it seems very open and shut to me. The future roles, so she's considering the future of the roles primarily by taking into account evidence on safety and effectiveness, which was the primary goal, but using some of the new views that she got. There were no convincing reasons to abolish the roles of AA or PA, but from a workforce perspective, there is some doubt about the need for the training of further AAs. There was no case for continuing with the roles unchanged, as there are several significant issues that need to be addressed to embed them into the workforce. And then we're now on to the recommendations 30 minutes into the video, or 30 minutes into my recording, certainly. Recommendation 1, positioning of the role. The role of physician associate PA should be renamed physician assistant, positioning the role as a supportive, complementary member of the medical team. I think we saw this coming. I myself have not at any point been a fan of abolishing the role, and I didn't think that was likely. The renaming, I think we saw coming. Many of the coroner's reports and the commentary revolves around the name being confusing and people not having understood as patients who they've actually seen and what their role and training is. Physician assistant is the role as it was historically called in the US, where the role began. Interestingly, they're now flipping the other way in some states. They are moving towards the physician associate title. However, in some places it's been blocked, is my understanding, for being potentially misleading. You know, how people will react to this, I don't know. Some people I'm sure won't care. I believe that the physician associate title is what's legally defined in the AAPO order, which is the legal instrument that covers the roles, PAs and AAs. All of this, I believe, and the Medical Act, I think, is due to be superseded by the GMC order at some point in the future, which is a new piece of proper legislation that's coming to reform medical regulation. So whether the name will be dealt with by changing something about the AAPO or it will feature in the GMC order, I do not know. Recommendation 2, credentialing. Physician assistants should have the opportunity for ongoing training and development in the context of a formal certification and credentialing program, and getting more stuff that becomes commensurate with that training, including the potential to prescribe and order non-ionizing radiation. So that there's a few things here. Again, this is something that I've argued is important, I think, for people's professional identity, that it's completely understandable that a PA that works for some amount of time in gynae or gastro or neurology or whatever, they will start to form a professional identity that marks them in that thing, so that they at that point will be a neurology PA, or that's how they would perceive themselves. And actually, I think giving people formal training opportunity or certification or something that marks them as that, someone that has done maybe a PG cert or a PG dip or a master's in that thing, just in the way that a clinical nurse specialist or someone like that would, I don't think that's a bad thing, personally. What responsibilities that would give them, I don't know, because obviously just because someone has done an area of further study, it doesn't necessarily license you or regulate you to do that thing. That is to say, I could do a master's degree in psychiatry, right, or a master's degree in urological surgery, and it doesn't suddenly give me license to go and practice those areas of medicine, because I'm not suitably trained or licensed within my scope to do that. So certification and credentialing, and then more roles and responsibilities aren't directly connected. Potential to prescribe, I don't know how this is going to go. I think there's lots of pressure to get PAs prescribing. there's been talk in the past that that would be done by the V300 non-medical prescribing course that that is common for other staff groups to do. That would take a public consultation, I believe, in order to be allowed to happen, because the roles need to go onto a list of roles that's allowed to prescribe. And the UK, we are already an international outlier in terms of the number of roles that can prescribe. So how that process would go, I don't know. And order non-ionizing radiation. Prof. Leng will upset the radiologists and the radiographers. We request a radiological opinion. We don't order scans. And she's kept that to non-ionizing radiation, interestingly. So that's MRI, ultrasound, etc., not X-rays, CT. Why she's made that distinction, I don't know. I'm slightly surprised to see it, but it's maybe buried in the wider report. Recommendation 3, career development. They should have the opportunity to become an advanced physician assistant, which would be one AFC band higher, developed in line with national job profiles. PAs at the moment are band 7, so whether she means that a working PA would be band 7 and go up to band 8 as an advanced, which I guess would be in line with ACPs, I think, and some ANPs. Whether after this the role will be rebanded to band 6 and then an advanced PA would be working at band 7, I don't know which way round she's envisaging this happening, but I mean, I obviously broadly agree that doing an advanced credentialing thing should see you paid more. To me, the devil is in the detail of what they're actually doing and what is in their scope of practice. Physician assistants should not see undifferentiated patients except within clearly defined national clinical protocols. This is welcome, I think, as far as I'm concerned. Undifferentiated patients are where danger lies. I've seen reference elsewhere to what she meant by that being triaged minor illness patients, but again, I would need to see a lot more detail. This also means practically that in some settings it would be very difficult to employ a PA, so GP or ED, I guess, are your two big undifferentiated work streams. I suspect that we'll see a lot of chicanery and jiggery-pokery from trusts as they try and find ways around this, like getting a consultant to eyeball someone first and then giving them to the PA to go and see. But I don't know, difficult without more detail. Newly qualified PAs should gain at least 2 years in secondary care prior to taking a role in primary care or a mental health trust. The RCGP, Royal College of GPs, has the stance at the moment that there is no role for PAs in secondary care, in primary care even at all. So how this recommendation interacts with that, I don't know. It depends, I guess, how much GP practices toe the line, essentially, to these recommendations. Recommendation 6, team working and oversight. The PA role should form part of a clear team structure led by a senior clinician where everyone knows roles, responsibilities, accountabilities, and each PA should have a formal named doctor taking responsibility for them. That makes sense, I guess. That seems like standard employment practice. Recommendation 7, identifying the roles. So standards to help people work out who's a PA, national clothing, lanyards, badges, staff, making it really clear who's a doctor and who's a PA. Again, very sensible. This was recognised multiple times in the various materials. People are finding the role confusing in terms of potential for being confused with a doctor. Everyone needs to do things to try and minimise that. Recommendation 8, professional standards. A permanent faculty within, it seems, the Academy of Medical Royal Colleges, or one of the Royal Colleges, I guess, because you need a faculty, is my understanding, within a college. Or I guess they can stand separately. But PAs need a professional home for their standards training, credentialing. I think that's, you need that. Like professionals, especially working in an environment like health, need that. That seems fair enough. I'm very wary of the academy taking that on, only because the previous leadership are well known to simply ignore dissenting voices. This got so bad that I think it was the trainee committee released a letter basically saying, help, they're not listening to us and not reporting what we say. So at the moment, I would not particularly like that to be the academy. I would like it to be a, reputable, freestanding entity that looks after them and looks after the credentialing. That seems fair. Then AAs. AAs should be renamed as physician assistants in anaesthesia, or PAA. I believe this is what the old name was when they were first introduced, and should keep using the scope of practice published by the RCOA. So Leng is actually endorsing college set scope there, which is good to see. She's not an expert in anaesthesia. Again, this is the same as PA, should have the opportunity for credentialing, and I think the RCOA one has a more advanced AAs feature in it, which is this. Any further expansion in the deployment of PAs should be taken in conjunction with the Royal College of Anaesthetists to build safe and effective models of anaesthesia delivery. Because I guess as we are now, there are different models that you could run. You could have consultants, trainees, that is doctors, and AAs. You could have no AAs at all and purely go back to being doctors. The way that AAs seem to work is being used as a multiplier, having one consultant anaesthetist who is your like expensive, time and money limited thing, looking after more people who are less expensive, and that's where your efficiency comes from. But that model has not been well supported effectively as of right now. Ongoing national audit of safety outcomes in anaesthesia practice in conjunction with HQIP, my gaff for the past year, who are very good at national audit, so I'm pleased to see that it's in their hands, looking at outcomes in cases with or without AAs, and then exactly setting up another faculty or a body, but this time under the Royal College of Anaesthetists to sort out all the standards for AAs. Then there are several wider recommendations. Permanent faculty, so I'm reading the same one. The GMC's requirements for regulation and reaccreditation in good medical practice should be presented separately to reinforce and clarify the differences between these roles and doctors. So Leng is saying to the GMC here, the way that you have set about outlining your regulatory standards is not appropriate, and that's very good to see. Like I'm pleased that someone is being firm with them, because they're kind of a law unto themselves in theory, at least. Supporting doctors as leaders and line managers. Doctors should receive training in line management and leadership. I agree with this. Doctors, often much earlier in your career than you'd think, you fall into leadership positions because you have to, because when something goes wrong, people look at you for help because you're the doctor, like, sort it out. And often, I think we are the best people to do that because we have much deeper training, essentially much deeper, broader, longer training than virtually anybody else. That means we should be taking on that mantle of clinical leadership, but often doctors are just not given the training, resources, job planning, etc. to do that, and that's not appropriate in a safety critical section of the workforce. Redesigning medical and multidisciplinary teams. There should be a working group to set out MDTs. I think we need a coherent view of what an MDT model actually looks like and who does what. As I said before, I'm not a fan of their train to task, not to role model. I think that's a terrible idea personally and goes against everything we know about professional development, but whatever. it's presumably someone thinks it's cheaper, which is why they want to do it. And safety systems should be routinely collecting information stratified by staff group against an agreed set of standards. This should have happened 20 years ago when these new roles were introduced. It's great to see it here, but it's very telling and really damning, actually, of leadership at the time that this wasn't just done, because it should have been done. It's not that hard to put in monitoring protocols. So then lastly, implementing the recommendations, we should use this review to reset the hostility surrounding this debate and stimulate effective collaboration for the future. I think personally, if people all accept this and the recommendations as it's written, then we have an opportunity to do that. I suspect that there will be very strong pushback from a subset of PAs and AAs, probably not all of them, because some of these things, some of these recommendations and the repositioning of the role almost very much as an assistant and supportive to doctors rather than this semi-autonomous clinical practitioner working a bit like a doctor, looking a bit like a doctor and doing the things that doctors do, that clearly does appeal to a subset of PAs. I suspect that those people are not going to be very happy, and from some PAs there will be pushback. From the union and those organisations there will almost certainly be pushback, and I can see some departments who have configured their services potentially unsafely, I should add, or at least as per this report without suitable safety evidence, if they've designed their services in such a way that they are reliant on PAs and AAs to do lots of the things that clearly they either shouldn't be doing or won't be doing going forward based on this report, then that is a really serious problem for them, and naturally trusts will try and develop weird workarounds, like I said before, or they'll simply not implement them and not tell anybody. And I expect that there are some senior doctors and management who will be so embedded and all in on workforce substitution and maps are the way forward that they will simply continue to run their own little fiefdoms and not do what the report says. To me, that is something that would be appropriate for whistleblowing. Not that I expect anything would be done, but at the point where you're ignoring the findings of a national government review, I think you're in a really precarious position if anyone comes to harm. The mistakes of the past must not be repeated. Clear leadership will be essential. Medical leadership will be a crucial element of success. If you do not bring the doctors on board with you, then you cannot achieve anything in the NHS, unfortunately. I know that many people will not like that. That's probably very obstructive to many of the changes that people would like to make, but that is how it is. Doctors are the experts that drive this care in the NHS, and you've got to do it in consultation with doctors and bring them on board, or it ain't happening. And many governments have tried and failed to change that. Some national agencies and bodies will need to take forward some recommendations. Others need to work together. Yes, the colleges, the academy, etc., and provides better care and more clarity for patients. And that then goes into the body of the review, which is too much for today. So I'm going to make a full video in time talking about the recommendations and findings of the Leng review, but that is a read and contextualization of some of the key issues in the background for the review and some of my early thoughts. So thank you very much for watching. Proper video coming this weekend, and yeah, that's it for now. I need to go to sleep. Thank you very much all. Take care. Bye bye.